Is it clear?
Very clear. And Vijay, just for the beginners,
Yeah.
you are not using any local anesthesia.
We have packed the nose with xylocaine jelly soaked gas piece, and we have removed it.
Okay.
And the patient already had terminoplasty, so a lot of space is there. So basically, the nasal pack is to decongest the turbinate and little bit of anesthesia, so that the patient won't get up while being stimulated with the endoscope. I'm using a nasopharyngoscope Olympus 2.4 mm. Doesn't have a suction channel, but I'm using it. I'm standing on the right side of the patient.
I think the surgeon picture, I think they wanted in the PIP. The pulse of that particular thing is just showing this monitor part of it.
Don't show that. No, here.
Is the anesthetist using any drying agent or he's not using any drying agent?
We are not using any drying agent, sir.
Exactly.
So
That is one of the
initially,
most important things to be remembered, no drying agent, preferably no local anesthesia. So both should be avoided as far as possible.
So this is a left side of the.
Like decongest the
So can you hear the snoring sound?
yes.
So we are going through the left nasal cavity.
Nasopharyngoscope.
Nasopharynx is fine, and the patient is in apneic episode. So you can see the vibrating palate. It's showing a nice anteroposterior collapse. So you have to at least wait for 3-4 cycles of apnea before concluding the pattern of collapse.
Excellent. Can we, would mic be kept near for us to hear the snoring part?
Yeah.
If it is possible.
You have any other mic?
So the second very important point which Dr. Vijay has said is wait for 1 or 2 episodes of apnea and snoring before you really assess the thing rather than the first one.
Because first time sometimes you may see like circumferential collapse changing into anteroposterior collapse or anteroposterior collapse changing into circumferential collapse. Can you hear the snoring sound? This mic is on.
So, to put it in a nutshell, the patient is in a supine position.
Yes.
The surgeon is to the right side of the patient. The flexible scope with the right hand, you are passing it through the left nasal and holding the main scope into the left hand and using the, what you call it, the knob to navigate the tip of the scope into the nose and then gradually into the nasopharynx.
Yeah. Perfect, sir. So now I am passing through the velum and crossing the velum, and you can see the oropharyngeal collapse. Can you hear the snoring?
No, no.
I think hand mic is not working.
Is it audible now, sir? Hello? Hello? Conference hall?
Take my mic and give it.
So vallecula is partly being covered by the tongue base, isn't it?
Yes. Minimal lingual tonsil, maybe grade 1, I would say. And okay. See, these things can happen when you don't anesthetize the throat or oropharynx. And usually these patients will be having a lot of laryngopharyngeal reflux and they will be very sensitive.
I think the tongue base, if you see there's some white spots, and many a time that could be because of the LPR itself.
Yes.
would be query fungus. Yeah.
Hello, conference hall, is it audible? Hello?
Prominent lateral pharyngeal bands on either side, and if you see where it is almost something like a circumferential narrowing with the vibration of the palate and part of the soft palate. Interestingly, if you see that the glossoepiglottic bone median one is a little shortened. That means that this patient epiglottic collapse, secondary epiglottic collapse
Shall we start the intubation, sir? I think. Can you hear? Hello?
Yep.
Sir, we are starting intubating. If we have any questions from the audience, we can discuss.
Then, Vijay, when they're intubating, I'll quickly ask you a few questions, maybe we should be able to put forward.
Yes.
In this case, the flowing is mainly palatal.
Yes. So we used to assess the oropharynx. We used to assess the oropharynx by keeping the scope at the level of lower part of the velum and look for the larynx. And if the epiglottis is partially blocking, we can say it is incomplete collapse of the tongue base. Or if the epiglottis is completely obscuring the epiglottis along with tongue base is completely obscuring the view of vocal cords and larynx, we say it is complete collapse at the level of tongue base. In those situations, we do Eschmach maneuver and assess whether any mandibular advancement device or external framework surgery will help or not. And also we can assess whether the tongue base surgery will also help. If we see only the primary epiglottic collapse, that is when the epiglottis alone is obstructing and we can see clearly the vallicula, then we do an interventional dice with nasopharyngeal airway and bypass the velum obstruction and see whether still the epiglottis is collapsing or not. If still epiglottis is collapsing, then we call it as primary epiglottic collapse and we may have to address it. After introducing the nasopharyngeal airway, if there is no collapse happening at the level of epiglottis, then that means that epiglottis which was collapsing is mainly because of the negative pressure created by the thorax because of the velum obstruction. I think that's clear, right, sir?
I think when you're talking in terms of three, number one is Glothrus, number two is positional. Do you want to also use positional only supine or to one side up, taking the history of the patient?
So usually I won't do in all the patients, so unless when we go through the sleep study and if it is very particular that the patient is having mainly apnea in supine position and apnea is also happening in the right lateral or left lateral position, then I would suggest to do a positional dice. So,
Third one, yeah, the interventional dice part of it. So when you pass the nasopharyngeal tube down, initially you go beyond the uvula or the soft palate. And suppose the patient's snoring stops at that time. Apart from looking at epiglottic collapse, does it also give you any other information?
yes, see, usually if it is 2.3 mm fine endoscope, we can go through the nasopharyngeal airway. Otherwise, I would prefer to go through the other nostril so that we don't block the passage of the nasopharyngeal airway, which is supposed to do its function. So we keep the endoscope just at the tip of the uvula because we want to see what is happening below that. And sometimes in few patients we have seen entire hypopharynx, the aryepiglottic fold, arytenoid, everything collapses and blocks the airway. So that can also happen, and that also be kept in mind while looking beyond the at the level of tongue base.
While we are waiting, can we just do a quick talk on decision making of Oasis surgery based on dice?
Yes.
As soon as you are ready, Oti, just tell me and interrupt me. We will come
Yeah,
back.
it will take another 5-10 minutes to set up here.
Yeah.
So in the meantime, you can have that lecture, right lecture at right time, I think.
Yeah. Yeah, I will do that.
Sure. So for this patient, Dr. Vikas is here, who is going to do the surgery, and he explains this plan. What is your plan?
Ready?
Your audio. Yeah, now we got.
All right. So, sir, allow me once again to keep my mask down so that my voice remains clear. And you understand this is an oral surgery, so sterility is not that big a problem.
Okay.
So, with your permission, I am keeping my mask down.
Okay.
And the coblation wand is getting ready. However, let me explain this case first. You have seen the dice in this patient. It was both AP as well as lateral collapse. The AP was more prominent, right? There was no tongue base. The patient's age is 38, so he has got a normal physiology, right? So, yeah. One, can I have a complete silence in the theater? Yeah, sorry, Sagar, you said something?
We didn't give the patient details for our audience.
Yeah, please go through the patient details. I would like that. Yeah, coblation I am setting up. Do you have another coblation machine if this does not work?
Was there any doubt? Because please write down the technical paper and pass it to the monitor and they will email given
जल्दी जल्दी लगाइए ना. Can you help the coblation to be set faster?
at the end of the day. We must have a live interaction at that time.
वो वन हटा के साइड में रखिए.
Patient had past history of undergoing separate organ on physical examination. Shows had an BMI of 20, a Sauban score of 5.
Which wand are we using? This one.
I'm getting ready this one, new one second.
Which is
Hello? Hello? Yes. OT2? Hall? Auditorium? Yes. Are you able to hear me? Yeah. Yes. We are going to demonstrate the second procedure. Dr. Tanvir will tell the patient details shortly, but before she tells, I'll just quickly do the dice because the patient is already given the Dexmed. And this is a 56-year-old gentleman who had a multi-level collapse with a severe obstructive sleep apnea, and this patient had I think you can see in the slides how severe the Stockbank score and the Epworth sleepiness score, and this patient had a DICE. This is the sleep study scores. AHI is 80 and low SAT is 43, and this patient had a very severe obstructive sleep apnea, and when we did the DICE there was a severe nasal septal deviation, adenoid tissue, all those things I will show you in the dice there. I think you are seeing the virgin dice. Yeah, we will show that dice later, but now shall I just show the dice what is right now here, because the patient is snoring very severely now. We have already done a turbinoplasty and the adenoid. Can you shift the OT please? Audiovisual. So this is the adenoid we just did 2 weeks back, And now we are going to show you the velopharyngeal collapse. This is the lower velopharyngeal collapse. It's a complete collapse. We are using a Pentax endoscopy system and a BIS monitoring also. I'll show the BIS monitoring, and the person will talk about the BIS monitoring shortly to tell the depth of the sleep and the level of anesthesia. So you can see there is a complete obstruction at the level of the velopharynx. It is a circumferential collapse. It's a circumferential collapse. The patient is going so far for an apnea. I'm just waiting for the patient to breathe. We are using dexmedetomidine. You can use either midazolam, propofol, or dexmed, but dexmed, we found it in our patients to be more correlating. You can have the BIS scores. Can you show the BIS scores there, please, with the hand camera? It is 73. Perfect score there. No, we want this one. No, but that is not clear, no. Oh, jaw thrust maneuver, please. You are doing a jaw thrust maneuver to open up the airway to see the effect of the jaw thrust to maneuver there. Very severe collapse. This is at the level of velopharynx, oropharynx now, and you can see even the collapse at the hypopharyngeal level. So now I'll try to do a interventional DISE. Can I have the airway? Nasal airway. OT నుంచి తీసుకుని. Meanwhile, I'll also, yeah. Meanwhile, I'll show from the opposite side nose. Jaw thrust, please. Yeah. Release the jaw thrust. Again jaw thrust. Yeah. Airway is ready. Yeah. Dexmedetomidine. Dexmedetomidine. ఎప్పుడు యూజ్ చేస్తే నేజల్ ఎయిర్వే తీసుకుని సార్ డోంట్ డూ ఇట్ సార్ నేను చేస్తాను. Just for a second, we will wait for the dexmed effect to go in. As we are trying to do the interventional DISE, there is a chance the patient may wake. So, name sir, please.
Do we have a possibility of having the picture in picture?
Oh, okay. Can you hold this? 1 second, sir. We will try to see. That's gone in totally. Patient is coming out. Just hold on for a second. Meanwhile, you can show the OT2, OT1 because the patient's depth of anesthesia is coming out. We are just shifting the IV line.
Yeah, so I'll explain what I've done, sir. Sir, as you can see, I have with the green suture is the absorbable one. I have gone from here, gone into the palatopharyngeus. I have taken and pulled it laterally. You can see that this suture is a little under tension, so there is a risk of this opening up. So that was just pulled a little more than what it should have been, and that's what I was telling, that there is no way to go back. If you pull more, then you cannot reverse it. So anyway, so then I came back, and this is, I have just taken a U-turn so that it does not open up, because scissor please. So the absorbable suture I have done on the right, done on the left, U-turn and cutting it over here.
Right,
No, this suture is not cutting. No, it's not cutting.
scissors.
All right. All right. So now this suture will remain in its place. Now you can see the non-absorbable. I have come lateral to the raphe. Can you see that?
Here,
Now I'll go from left to right. So this is exclusively for AP collapse. So this area is below the action of the levator palati. So I'll go from right to left. I have already come, and now I'll go from left to right. Again take a U-turn and cut it off. So what is important is to put it right in place. Can you see this?
Auditorium, please. Can you show me only one quick second?
Okay,
I'm
audiovisual
doing an
shift to
interventional dice.
OT2 please.
here, yeah,
Yeah.
Sanjay, we are with you.
So we have passed the airway.
Can you change the 2 to the
And
other side?
in spite of the airway, you can see that there is a lot of collapse there. Can you see the epiglottic collapse, sir? Primary epiglottic collapse is there in spite of doing this. So which means this patient would also require a epiglottic procedure later on. So today we will only demonstrate the palatal procedure. We have got the consent to do it in stages. So we will be doing the epiglottic procedure later on if the patient is not improving, sir. So this is the nasal airway that we have passed in.
I think very well demonstrated, this patient will require an epiglottic
Yes, sir.
procedure at a later date.
At a later date. Okay, so I will give the mic to your good name, madam? Anaha. Anaha. She will quickly talk about BIS scores and what is the importance of BIS. But if Vikas is ready to show something, she can talk while they are intubating.
Sanjay, can I just quickly
Yes.
short discussion with you?
Yes, sir.
See, this patient, normal, in the normal circumstance,
Yes, sir.
combine a zeta palatopharyngoplasty with a partial epiglotectomy.
Yes, sir. That is the plan, sir. We are going to proceed with zeta palatopharyngoplasty for this particular patient. This kind of very severe patient needs an aggressive procedure like at zeta, and I would have done a partial supraglottic, suprahyoid epiglotectomy for this particular patient. But I don't want to do a lot of procedures, especially during this time. We will definitely stage it and do it as needed later on, the epiglottic part. Because it's a very severe collapse, sir.
Can I just put forward a discussion, not for this, in general to the audience?
Yes, sir, you can talk about the two major and one minor. Those things you can tell them, sir, because that is important for the delegates to take home message kind. Because if he is ready, yeah.
Under normal circumstances, if in case you
All right.
patient out of anesthesia, counsel the patient and the relatives, and do both the procedures together. Keep the patient for a day in SICU, and both the things can
Artery.
be completed in one sitting.
Artery. All right. Am I with you, sir?
Yes, Peter.
So, sir, as you saw, I went from left to right, right to left, and left to right. Now I've come out lateral to the raphe, right?
Yeah.
So this is our support, and now we'll have to cut it off. But before cutting, I'll again take a U-turn, because the moment you take a U-turn, your suture would not come out easily. Because see, there was the loop is inside. We went to the other side, came back here, and we'll just take a U-turn for a short distance in any direction, doesn't matter, almost a 180 degree, so that, now give me a scissor. So I'll show you the effect of this surgery now.
Yeah.
No part of the non-absorbable suture is visible. The loop of the absorbable suture I have kept visible, so that I know what is happening, because this is anyway going to fall off. I am not bothered about this. The AP collapse is completely eliminated. AP was his major collapse, is completely eliminated because the soft palate was here, right? I have reduced the length by almost 1.5 to 2 inches. The uvula was almost till here. This much I have already removed. The lateral collapse, the AP collapse was also contributed by this posterior pillar, which I have transposed laterally. The lateral collapse is pulled. The lateral collapse was because of this area, which is already pulled, because I have pulled the posterior pillar. So the whole complex is tethered to the pterygomandibular raphe. So this raphe is anterior to the soft palate and lateral, and therefore now this is acting like a suspension bridge. Lateral is by absorbable thing, and anteroposterior by a non-absorbable suture. Now we do not have any solution for the posterior pharyngeal wall collapse. I have done in one case, I have done a non-absorbable suture. I have gone from here, taken it and come back and gone to the other side. So I have also taken care of the posterior pharyngeal wall collapse and the hypopharyngeal collapse here. So I will not talk about, because I have only done one case so far. So let me see the long-term results. But barbed suture, non-absorbable, is the key. So non-absorbable was not used by anyone on this planet before, and therefore I had to think many a times before using it. But now I have used almost 200 plus non-absorbable sutures. They remain in palate very well. They do not come out. The absorbable ones, on the other hand, may actually come out from here. But even if they stay for 15 to 20 days, our healing will happen. Now, when the person is swallowing, important is that why you do not want to go through the midline. Can I have the pillar retractor? Yeah. So I'll show you how much of space is created at the back. Now see, this much of space is at the back, sir. So I think it is around 1.5, yeah, whatever, 1.5 to 2 centimeter at the back. Now say there is enough space. This part which used to go and collapse is not there. So snoring is almost eliminated if he is not mouth breathing. And
So velopharyngeal insufficiency.
yeah, so why it will not happen? Because I have not touched the levator palati. Now see, when the person is swallowing, the soft palate can still move superiorly. Can you see that? It cannot collapse posterior, because I have, this is anterior, this is posterior, and I have sutured it in this way. But it can always move superiorly. So this patient would have no velopharyngeal insufficiency beyond a couple of days. If at all, because of pain and all, he will find it difficult to, pull his soft palate. But I have not touched the levator palati muscle. The tensor palati is here, the levator palati is here, and I have not touched the levator palati muscle. So the VPI is lesser than the zeta, because in zeta you take away all this and put sutures in the area where the levator is here. Here I have not touched the levator palati at all. See, this whole soft palate is free to move, completely going and touching at the back. Got it, sir?
Yeah, I think maybe in person we'll have a discussion.
Right. Any audience have any questions on this? Now, in mild sleep apnea cases, you can also do a uvulopalatopexy. in which you just rotate the uvula, make a raw area, stick it over there. So I do it in simple snoring and mild sleep apnea cases, not in such severe cases where you saw everything was just completely collapsing, it was not vibrating.
Post-operative global sensation in these patients
Is much lesser than when you use the cautery. If you use cautery, then it is much more. The globus is more because, see, I'll tell you, sir, this was the soft palate, right? When we use cautery, we make it on, and when we put multiple sutures, we make it a hard palate. So if you make soft palate hard, you will get globus. Here I have gently cut the soft palate. Obviously, there is going to be a little bit of fibrosis, but with coblation, the fibrosis is least. There is no mucosal loss here, completely preserved. See, little bit of mucosa here on the palatal side is already preserved. Sometimes you can actually preserve a little bit more of mucosa and close it. But all those things will not really make too much of difference if you use coblation. If you use and you saw, I hardly ever used coagulation. It was only ablation. So ablation will give least fibrosis. So the globus sensation is much, much less. And it's not a real major problem for patients. I've been operating for so many years with coblation. So that's my take on that. Yeah. External camera, please. Yeah. Sir.
You are using different types of box sutures.
Yes.
First absorbable, then non-absorbable.
Right, sir.
Why can't you use non-absorbable alone?
Correct. So on the lateral side, my sutures are 2-3 loops and they are exposed. You cannot have a non-exposed suture on the lateral side.
Okay.
Therefore, and what we want is 15 to 20 days the flaps will take up. But a AP is a collapse. See, I cannot resect too much. I cannot go very high. If I resect much higher, then I do not need anything. But I have resected only the adequate length, and I still do not want the rest of the length to completely collapse. Now, Deendayal sir had asked that, what if the higher base tongue is collapsing? Higher base tongue will be supported by my non-absorbable suture. It will sit right on the soft palate, right? So I am not bothered about high base tongue collapse. Anyway, there is no surgery for high tongue base collapse. The lower tongue base collapse was not a problem. High tongue base collapse was not happening in this case. But if at all it happens, my suture, the suspension bridge, has two functions. One is to not let the soft palate collapse, and one is to not let the high base tongue collapse. It will suspend both. And therefore, you saw how much time I took to put those sutures correctly in position and very deep into the soft palate. So this non-absorbable will remain for life.
So for the lateral collapse, you are advising us to use absorbable.
Yeah, or you can simply use Vicryl also.
Vicryl also.
Yeah. Only thing is that Vicryl, you have to take 2-3 times stitches, time is more, but results will be the same. Laterally, you can use Vicryl. No problem.
If you are giving information about where to get this absorbable and non-absorbable box sutures,
Yeah.
it be useful for us.
Yeah, so Vicryl 20 round body. 20 non-cutting round body needle, so that you can, without trauma, you can approximate the flap laterally with the pterygomandibular raphe, which you can very, very well do with Vicryl. You do not need a barbed suture if you do not have. But for this AP collapse, this suture hardly costs 3,500-4,000 rupees, so it's not very expensive. It was not available, so I researched on it, and I got a consignment from the US around 100 pieces. Then I got another consignment. So now they are actually importing, because many of my friends are using it. So
Where to get it?
yeah, it's from Covidian.
Nose.
Yeah, it's from Covidian.
Video.
Yeah, Covidian is now bought over by Medtronic.
Okay, great.
30. You can say that I'm only using it, so if you tell my name, they will give it to you.
Oh,
Right.
great.
So now there's a paper already published, sir, last year, so you can safely use it, because we have published a paper, so legally you can use it. And this was the absorbable one. This was recommended to us by Dr. Professor Vicini, what he uses in Italy. So I started with this, but then obviously it will last for 3 to 4 months only. So I shifted on to non-absorbable.
Great, thank you.
Now this patient, Sagar has told me that you have to guarantee that his snoring will go down at least 80%. Now, guarantee is not the word that we use, but I am sure that he will snore much, much lesser. If he does not mouth breathe, then he will practically not snore. But if he mouth breathes, then he will keep snoring. For that, we'll have to give him a chin strap.
That guaranteeing part seems to be a little dicey.
Naturally, sir, naturally. Sir, but unfortunately, we are in changing world. We are in changing world. Like we said that for adenoids, we always used to say recurrence is a possibility. Now, if we say recurrence, we have to give assurance that it will not require a surgery again. Even in polyposis, we have to give a assurance that a surgery is very, 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 very unlikely to be required again. We cannot say that we will operate you every few years, even in polyposis. So times are changing and we have to change with time. We have to evolve in our technologies, in our techniques, so that we can give whatever work we do has to be the final work. We cannot say that we'll try our best, whatever happens, we'll see we cannot say all that. At least in my practice, people do not accept.
Now, the word here, we cannot say cure for snoring.
No.
But definitely improvement.
Right, absolutely. So we have to at least assure that there will be a 70-80% improvement. Otherwise, why should somebody undergo a surgery, suffer from pain and this and that? Nobody should do that. So we have to, if we are doing something, we have to be sure that yes, we'll get our results. If we do not get, then we should not do the procedure. That's my personal take.
So I have about 2 to 3 points pertaining to this snoring, which I thought it would be nice to discuss with you. If the site of snoring is palate, and what you have done would definitely improve. But there are certain times, apart from palate, it could also be supraglottis. It could also be to some extent tongue base. So we need to keep these 2 additional points in mind before we talk in terms of snoring. Number 2, what I thought was snoring is always judged by the bed partner, not by the patient themselves. They will not talk. It is the person who is sleeping in that room with that person talks about snoring, and there could be a level which that person is viewing will come and create trouble for you. So maybe we need to keep that point also in mind.
Right.
Bed partner. Number 2, other site where the snoring could have happened. Number 3, the dental part of it. If the patient has got an underbite or an overbite, and that is where the tongue doesn't come and sit in the resting position in the night, and in a supine position, these are the cases that will again have snoring because the tongue falls back. So the reason why I am a little skeptical about snoring is I am very happy giving a good result for AHI. Snoring we have to be very, very careful. Keep in mind the bed partner. She might have some other thinking in terms of that person is concerned that I can't sleep in the same room, I sleep separately and all. And you try to do it, they will not accept. 2, underbite, overbite. Dental consult is an absolute must before we take it. 3, I think our dice should be able to talk in terms of tongue base and also supraglottis.
Yeah, so I think a very, very valid point sir has raised, that snoring sound. See, we have to develop measures that what was the snoring initially, what is the snoring. Like we have developed AHI, which is obviously has a lot of flaws, but still there is some measure to measure the success. For snoring, we have to measure the loudness, the quality, and other measures. Maybe next 5 to 10 years, a lot of apps have come. It will happen so that we can prove that the snoring sound has gone down. DICE has definitely let us know what is happening today and what will happen later. So interventional DICE was again started by us around 10-12 years back. The word interventional DICE was not used by us, it is being used by some papers now. So DICE will tell you what is happening today and what can happen later. Now in this case, the tongue base was not a problem. It's very unlikely that tongue base will start collapsing later, but it's still a possibility. You cannot rule it out. We'll be able to have maybe under 10-20 years more predictive measures. How can you predict before surgery that you'll get a long lasting result? So we are improving, we'll keep on improving. So I think very, very valid points. So when you are a newcomer, do not jump onto conclusions. There are many factors which are being evaluated today, right? Mouth opening was something which we never thought. But we realized that we'd done such a good job, but the patient mouth is still open and is still, now the tongue has started collapsing. Earlier it was not collapsing. So we have gone through all that.
Last question, because interesting one. What is your longest follow-up of this non-absorbable suture?
4 years, sir. 2019 I started, late 2019, so 4 year and few months. Rejection is not a problem, absolutely not a problem. My technique was faulty initially, so few of them came out. I still have some extrusions somewhere because my technique is not perfect. I'm perfecting it. I showed you I start 1 centimeter lateral so that it takes strength of the whole raphe. Because if it is not tight, if it is not sitting tightly, then the whole thing will open up. So it has to sit firmly. Should not be very tight, it should not be very loose. So I think it was my technique fault. It's not the suture's fault. I'm improving.
The directional healing vector in this particular part, is it more on a narrowing level or does it open up more superolaterally?
Yeah, so why I started using barbed suture first of all, because earlier I was removing the part of the posterior pillar along with the tonsil. The surgery was very quick, 15 minutes UPPP was over. And healing was also pretty fast, no question of any wound dehiscence or suture falling, nothing. But the healing part of the posterior pillar, it used to pull the soft palate little posteriorly. So my retropalatal space would reduce by a few millimeters, and that would impact the results. The moment I start using this posterior barbed suture, while healing, the palate is kept anterior, so it cannot go posterior. It heals in the anterior position. That gives us a very good result. So directional healing is one of the reasons that I have used barbed suture. I initially used absorbable barbed, so that also did the work because the healing would happen in 6 to 8 weeks time, or maybe 3 months time. That time the suture would stay. But then I thought, why not use non-absorbable suture, which will stay for life? And now, I mean, many of my friends in Mexico, obviously US they are not using because the paper has just come out, but in Mexico, Rodolfo has been using this for quite some time. He's also very happy with the result. And some other places people are using it. And I think some of our friends are also using it. I don't think there's any problem with that, sir.
And very well demonstrated with us. Let's give a nice applause.
Thank you, sir.
And I will add up, it looks like a combination of a Fairbanks uvulo-palatopharyngoplasty plus relocation pharyngoplasty
Plus barbed suture.
plus Vikas Agarwal suspension bridge.
Correct. So I am constantly modifying my techniques, sir, to the best. Yeah.